You can start, please.
Yes, sir. Good evening. I welcome all of you in this 10th session of IAP NRC General Club. I welcome our chairperson, Dr. Rawat, sir. And I also welcome ma'am, our coordinator, Dr. Indu, ma'am, and our national expert, Dr. Joseph, sir. Welcome, sir. And I also welcome Dr. Harish Pemde, sir, who is a session expert in this session. And sir is Director Professor in the Department of Pediatrics in Lady Hardinge Medical College, and he is also my teacher. And sir has many activity in the IAP. And I also welcome Dr. Anjali Sisodia, presenter. She is senior resident in the Department of Pediatrics in Chacha Nehru Bal Chikiৎসালয়, and she is presenting this journal today. And I also welcome Arpita Chattopadhyay, assistant professor in the Chacha Nehru Bal Chikiৎসালয়. She is acting like a session mentor. So with these words, now I am handing over the session to our national coordinator, Dr. Indu ma'am, to take carry forward. Ma'am, please.
Yeah. Thank you, Dr. Ajay, for yet another session. I welcome our session expert, Dr. Harish, and Dr. Anjali, our presenter for this session. We have chosen a topic today which may be a little lesser discussed topic and an article which does not have too many cases. So Dr. Anjali had concerns whether this is the right choice, but then I told her it's what we need to discuss is the methodology and not really worry too much about the inference of the article. But I think it will be a good learning even on that end, because we are talking about a little lesser discussed topic in the pulmonology field, in immunodeficiency and interstitial lung disease. So over to you, Dr. Anjali. I think you can share your screen and start. And we have Dr. Joseph with us, who is a huge value addition, who actually makes us see light and makes us see the truth about every article. And we don't get swayed any longer by any article which is published anywhere, thanks to all his inputs that we have been receiving. It's made us really wiser. Thank you so much, Dr. Joseph, for being with us all the time. Over to you, Anjali. You can share your screen now.
Thank you so much, ma'am. Good evening to all present over here. I'm Dr. Anjali Sisodia. I'm doing my senior residency from Chacha Nehru Hospital. So today we are presenting this general review club. Are my slides visible, ma'am?
No, not yet.
No.
Okay.
Dr. Ajay, can I say some few words?
Yes, sir.
Sir.
So first of all, I must thank the NRC, the chapter, for inviting me. And I must tender my apologies that I am out with family. So I won't be able to continue the whole session. So I just only give my initial comments. As Dr. Indu was saying about the choice of article, I was also a little surprised to see this article. But this is one good learning, that even good retrospective studies can be published. And I remember, as I was member secretary of our ethics committee, we have given approval of many retrospective studies. And so, and hospitals like Safdarjung Hospital, Kalavati Hospital, and many other hospitals have large amount of such material available. And often we hesitate in doing this kind of a retrospective analysis and presenting as a paper. So this should be appreciated. And because this paper has only 11 cases of interstitial lung disease, which they are presenting as a case series. So case series provide lots of information, and we should, I think this paper presentation of the Journal Club will promote more and more such research which is there, and lots of clinical material is available in almost all the hospital. We should not hesitate and present them as a retrospective research, which is rather easy to do. My best wishes for the chapter and my best wishes for the presenters. Thank you.
Thank you, sir.
Thank you, sir. Yes. Anjali, you may start, please.
Yeah, we can
yes,
see your screen. Yeah, you can go ahead.
Sir, I've already shared the slides. I hope they are visible.
Yes, they are.
Yeah, thank you, ma'am. So The topic for the article that we have chosen today, it is the interstitial lung disease in children with selected primary immunodeficiency disorders. It's a multi-center observational study. The article was published in 2020, and this is a study from Poland. So the research question that we have looked for over in this paper was, what are the most common interstitial lung diseases with specific phenotypic categories in the inborn errors of immunity in children? The little background knowledge that we have is that interstitial lung diseases always poses a relevant cause of morbidity and mortality among patients with primary immunodeficiency disorders, and it may sometimes be the first manifestation in primary immunodeficiency. And most of these studies are basically in the adults, and the data in children is very sparse, so that lacunae needs to be addressed. Now, Al-Kadi et al. Studied 30 children and reported the prevalence of inborn errors of immunity among childhood onset interstitial lung disease cases was about 20%, and chronic granulomatous disease was most frequently diagnosed inborn error of immunity. Up to 90% of combined variable immunodeficiency in adult patients was studied for lung complications, among which granulomatous and lymphocytic interstitial lung disease was the most common non-infectious complication. So this is an Italian study. It's an adult study in which the granulomatous lymphocytic interstitial lung disease was studied in common variable immunodeficiency patients. And they it was a multi-center retrospective cross-sectional study in which 73 patients were studied with radiological features of interstitial lung disease associated to combined variable immunodeficiency versus 125 patients of combined variable immunodeficiency without having any interstitial lung disease. So in granulomatous lymphocytic interstitial lung disease, there was a higher prevalence of splenomegaly, autoimmune cytopenias, and bronchiectasis. Also, granulomatous lymphocytic interstitial lung disease patients showed lower total lung capacity and gas transfer percentage of predicted. And multiple other studies, like in treatment strategies of granulomatous lymphocytic interstitial lung disease, in common variable immunodeficiency, these are all adult-based studies. So the critical appraisal skills program tool, which we have used for this observation to criticize this observational non-interventional study. This is a snapshot of that. Now, the study design and ethics. The title is Interstitial Lung Diseases in Children with Selected Primary Immunodeficiency Disorder, a multi-center observational study. This title is per se not reflective of the objective. They have written the selected primary immunodeficiency when the inclusion criteria, they have mentioned mostly common variable immunodeficiency disorders. It's a study design, it's a retrospective multi-center observational study. The duration says from 2012 to 2019, but the months have not been specifically mentioned. And the two centers involved in the study are Department of Immunology and Children's Memorial Health Institute of Warsaw, and Department of Pediatric Pneumology and Allergy at Medical University of Warsaw. So basically coming to a multi-center study, but the two centers are in the same city of a country, Poland. So not a widespread data available. The objective of the study was, it's a retrospective analysis of clinical, radiological, and histological characteristics, as well as the treatment strategies and outcome in a unique group of children with primary immunodeficiency related interstitial lung disorders, predominantly combined variable immunodeficiency. But the research question, the primary or the secondary objectives, what they wanted, but were not clearly outlined. Coming to the inclusion criteria, the age cutoff of the children are not mentioned. And established primary immunodeficiency criteria has been used, but none of the criteria are being mentioned in the in the study. So this is one criteria of CVID because they have studied mostly combined variable immunodeficiency. I have taken the snapshot of that. That combined variable immunodeficiency criteria, which should contain at least one of the following, that is increased susceptibility to infection or autoimmune manifestation, granulomatous disease, or unexplained polyclonal lymphoproliferation, or any affected family member with antibody deficiency, and marked decrease of immunoglobulin G and marked decrease of immunoglobulin A with or without low levels of immunoglobulin M, with at least one of the following, like poor antibody response to vaccines or low switched memory B cells, with exclusion of secondary causes of hypogammaglobulinemia, inappropriate age, and profound T cell deficiency. So, the inclusion criteria that they have mentioned was definition of primary immunodeficiency related to ILDs by the clinical signs and symptoms, the tachypnea defined as respiratory rate more than 90th centile, the retractions, crackles, and typical CT findings, and histopathology of lung biopsy findings were consistent with granulomatous lymphocytic interstitial disease, cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia, follicular bronchiolitis, or lymphoid hyperplasia. The detailed immunophenotyping and genetic studies using next generation sequencing, Sanger sequencing, or fluorescent in situ hybridization were performed in 6 to better characterize this outcome. So, and few of the patients, the genetic testing was not performed. And laboratory and molecular studies combined immunodeficiency was diagnosed in 3, one with Nijmegen-Bricket syndrome, one with Dijot syndrome, and one with LRPA mutation. So this has been mentioned in the inclusion criteria. However, this should had been a part of methodology. Like what they have done is already mentioned in the inclusion criteria. The exclusion criteria of the study states other interstitial lung disease, cystic fibrosis, and active infective lung disease. However, many mimics of combined variable immunodeficiency, like chronic suppurative lung disease, such as primary ciliary dyskinesia, patients on immunosuppressive medications, and post-transplant patients were not excluded. So, did the study address a clearly focused issue? To be honest, no, because the population studies, the children stated primary immunodeficiency related interstitial lung disease. They were consulted and treated consequent. There were no risk factor studies. The outcome measures were not defined. The clinical, radiological, and histological characters, treatment strategies, and outcomes were defined in they have said in primary immunodeficiency. However, predominantly combined variable immunodeficiency has been studied. So the study population was selected in an acceptable way. This is a case series, and there is no comparison or a control group. There could have been a selection bias because they have selected primary immunodeficiency but studied CVID. The cohort was representative of a defined population because mostly combined variable immunodeficiency was studied. And the source of the data is definitely an electronic based database with all medical records, but there are always chances of human errors, of not entering data or getting misplaced. So yes. Then accuracy of measurements to minimize bias. Yes, demographic data, in the demographic data, the ethnicity is not being mentioned. However, we know that ethnicity is uh, quite linked with primary immunodeficiency disorders. Then clinical signs and symptoms include respiratory symptoms, distress and respiratory failure, splenomegaly, lymphadenopathy with autoimmune anemia, thrombocytopenia, and chronic lung diseases. Lab workup, including basic CBC to detailed immunological screenings, then pulmonary function test, spirometry and diffusion capacity of carbon monoxide. Imaging include HRCT and chest MRI. Then histopathology and treatments including corticosteroids as first line, and then coming to steroid sparing agents and immunoglobulin replacement therapy. So were the subjects classified into exposure groups using the same procedure? So there are no comparison or control groups, and there is a heterogeneous basis of investigations being done. Like volumetric CT scan were done for only 8 patients. Spirometry could be performed for 9 patients, and lung biopsy could be performed for 8 patients out of 11. Then this is a small slide for pulmonary function test, what they have considered normal and abnormal. So for forced visceral capacity, forced expiratory volume in 1 second, and their ratio more than fifth centile were considered normal. Anything less than fifth centile was suggested as obstruction. Then diffusion capacity of carbon monoxide between between 5th to 95th percentile were considered normal, and less than fifth centile, total lung capacity less than fifth centile was considered to indicate restriction, and more than 95th centile was considered to be air trapping. So any confounding factors were taken in the design? No, all the parameters which were available for all the patients satisfying were not available. And the numbers are very few to draw any statistical significance. It's a very small case series. Then coming to the results of the study. So demographics and key summary. All the patients study are total patients included are 11 and all are male. The median age of primary immunodeficiency diagnosis was 9.5 years, ranging from 4 to 17. They have studied 796 patients from 2012 to 2019, out of which 11 had interstitial lung disease. Out of those 11, 2 patients had combined immunodeficiency. One had Nijmegen-Breakage syndrome, one had Dye-George syndrome, and 9 patients had combined variable immunodeficiency, out of which one had a genetic diagnosis of LRBA mutation, and 3 patients, there were no genetic mutations were confirmed. So the diagnostic workflow is like from clinical, then to imaging, then pulmonary function test, and finally performing the histology. Coming to clinical, the respiratory involvement was seen only in 5 patients. Diagnosis of interstitial lung diseases preceded the diagnosis of primary immunodeficiency in 2 patients. The median age or diagnosis of interstitial lung disease was 6.5 years, ranging from 2 to 16 years. However, 3 patients presented with life-threatening respiratory failure. Then the radiological findings, multiple poorly defined nodules, 2 to 30 mm with variable density was the most common finding. Solid nodules with ground glass halo was found in 4. Lesions formed rosette and tree bud pattern in 4. Interlobular septal thickening in 1. Irregular linear opacity in 1. And hilar mediastinal lymphadenopathy in 7. So this is a slide showing multiple poorly defined nodules with ground glass halo in a image before treatment, and in B it was post treatment. Same the X-ray, the C image showing the X-ray prior to the treatment, and D the post treatment. Pulmonary function tests were performed only in 9 patients, and the most common was air trapping, which was noted in 5 patients. Restrictive pattern was found in only 1, and reduced diffusion capacity of carbon monoxide was in 2. Mostly small airway involvement was more common. So this is the table which they have given, in which the residual volume upon total lung capacity is seen in patient the more than 95th centile is seen in patient number 2, patient number 4, patient number 9, patient 10, and patient 11. So in mostly it is showing air trapping, and in one patient where it is patient number 3, it is 0.78. It's showing obstructive pattern. And diffusion capacity of carbon monoxide, it's mild to moderate, more in 97th centile in patient number 9. Then coming to histology, histopathology methods used, it was either a surgical or a transbronchial lung biopsy, which was performed in 8 patients. HNE staining and IHC markers were used, and the patterns which were evaluated were lymphocytic interstitial pneumonia, follicular bronchiolitis, cryptogenic organizing pneumonia, granulomas, and granulomatous lymphocytic interstitial lung disease as an umbrella diagnosis. The results were granulomatous lymphocytic interstitial lung disease was diagnosed in 8 out of 7 biopsied patients, and lymphocytic interstitial pattern was more predominant, that was in 5 out of 7. The diffuse interstitial and peribronchial lymphocytic infiltration was found. Granulomas, non-necrotizing, were found in 2. Cryptogenic organizing pneumonia and follicular bronchiolitis was in 1 case, and multiple non-necrotizing granulomas were found in Nijmegen-Breakage syndrome. Coming to the treatment strategies being used, all the patients were on immunoglobulin replacement therapy. The first line was for any systematic or symptomatic or progressive disease was corticosteroids. Second line came to steroid sparing agents as azathioprine, mycophenolate, rapamycin, and cyclosporine A. Rituximab and abatacept, which has been reported in literature to be used for refractory granulocytic lymphocytic interstitial lung disease, was not used, and hematopoietic stem cell transplant was done for selected cases. So, coming to what was the treatment given, 8 out of 11 patients received immunosuppressive therapy in addition to immunoglobulin replacement therapy. 3 patients were very stable to get any kind of therapy other than immunoglobulin replacement therapy. So, corticosteroids were used in all 8 patients, out of which 2 also received IV steroid pulse dose. Then second line agents were used in 4 patients due to either partial or non-response or either toxicity. 3 patients which were without immunosuppression due to mild and stable findings. 1 patient had to go for a hematopoietic stem cell transplant with subsequent radiological and clinical improvement. So these are the treatment strategies being defined, in which the patient number 1, the steroids were used, and second line agents were also used, but due to progression of lung infiltrates and persistent lymphadenopathy, he has to further go towards hematopoietic stem cell transplant, which was complicated by infections such as human herpes virus pneumocystis, and then had to undergo splenectomy. But his clinical outcome was good. Then patient number 2 and patient number 3 received pulse dose therapy. The rest others were given steroids and other steroid sparing agents. So coming to the reliability of results, the strengths and weaknesses are as follows. So first of all, it is a rare complication of a rare disease. Incidence of combined variable immunodeficiency in general population is 1 into 25,000, and out of combined variable immunodeficiency, the incidence of granulomatous lymphocytic interstitial lung disease is 8 to 20% in CVID patients. This is what I have been able to find in the literature. Another strength being it is a multi-centric collaboration, and the European Society of Immunodeficiency criteria is used. Also, as it is a rare study, the retrospective analysis seemed quite reasonable. However, the weakness is it's a very small sample size, only 11, and being a retrospective design, there could have been missing data, the incomplete genetics testing performed, or non-uniform assessments, and there is no control group as it's a case series. So basically, coming to a very small sample size, it could be considered as a strength or a weakness, both, because it's a very rare disease that is studied. So finding more samples to get an even better study is quite difficult. Then the result of the study fit with already available in the literature. So yes, granulomatous lymphocytic interstitial disease and lymphocytic interstitial pattern are the most common ILDs that we find in combined variable immunodeficiency patients. Also, steroids are used as first line therapy and often needing additional or steroid sparing agents. The second line agents and targeted therapies are also widely used. Rituximab and abatacept are not used in this study, but however, the studies in adults show their use also. Pediatric studies are very few and call for more multi-center studies. Then the adverse effects observed of the treatment were Cushing syndrome was seen in 6 patients who were on systemic corticosteroids. 1 patient developed steroid-induced osteoporosis. Azathioprine caused pancreatitis in 1 and hepatotoxicity in 1. Rapamycin caused transient cytopenia and elevated transaminase in 1 patient. And post-hematopoietic stem cell transplant, human herpes virus and pneumocystis jirovecii and streptococcus viridans was found in 1 patient. Then comparing pediatric and adult granulomatous lymphocytic interstitial lung disease. So in pediatrics, generally presentation is more acute, less fibrotic changes, and they are more steroid responsive. However, in adults, it's a more chronic and indolent course. More fibrotic patterns are observed, and they need more of combination therapies. So, the bottom line comes out to be that early detection in children prevent irreversible fibrosis and can improve outcomes. So, from the literature, this I was able to find out that granulomatous lymphocytic interstitial lung disease shortens survival in combined variable immunodeficiency. However, this is an adult data, but pediatric implications are similar. And this study shows heterogeneous presentation from incidental radiological findings, CT done because of generalized lymphadenopathy, finding radiological features similar to ILD, to respiratory failure. Then corticosteroids are effective, but side effects are more common. And we need more standardized guidelines and more pediatric specific algorithms. So coming to what are the implications of the study. One observational study rarely provides enough evidence to recommend recommend changes in clinical practice. And for rare events, observational studies only provide evidence. Then recommendations from observational studies are always stronger when it is supported by other evidence. The conclusion from the journal is that PID, primary immunodeficiency related interstitial lung disease in children, is very heterogeneous presentation, and sometimes interstitial lung disease can precede the diagnosis of primary immunodeficiency. Then optimal treatment of primary immunodeficiency related interstitial lung disease is lagged by clinically proven treatment regimens. GLILD is predominant histologic patterns, and steroid are most effective. Then coming to the appraisal summary, the positive factors are that it is a multi-center collaboration, so better results. Comprehensive diagnostic approach has been used. Mostly the testing has been done in maximum number, or tried to be done in maximum number of patients. The results that they have got are confined with the existing literature, and it is a rare complication of rare disease. So yes, the negative points are it's a very small sample size, it's a retrospective design, the heterogeneous nature of investigations being done, and no control group being defined. And the unknown is since because of heterogeneous investigation done, the other kind of ILD might have been missed in primary immunodeficiency. And that's it, sir, from my side.
Thank you, Anjali. It was so it's the first time that we have actually done a case series on this platform. So the reason to even choose this is that we have been doing other formats of studies, but the case series have never been done. And since you picked up a rare disorder, the case series kind of gets justified. But even if you pick up a case series, how to analyze the data is very important of the case series, whether you put it on an Excel sheet and then you analyze it. I wanted to ask you one question, that though there was you had granulomatous interstitial lung disease, were all the patients subjected to a genetic testing to confirm a PID in them later of all this, the cohort, or because granulomatous interstitial lung disease can occur even beyond immunodeficiency. There are many other causes for GILD.
Yes, ma'am. So they have done, ma'am, lung biopsy was done only in 8 out of 11 patients, but the genetic testing was performed in all patients to reveal a few of the mutations, or not all mutations were diagnosed, but they tried to do that. Yes, ma'am.
So there, it is a possibility that some of them may not have been a PID, and it could have
Uh,
standalone. And could that be a negative for the study?
Ma'am, basically they have selected primary immunodeficiency patients, and only workup was done for ILD was detected in primary immunodeficiency. So basically all the patients were primary immunodeficiency patients, ma'am.
They were genetically not proven, they were proven otherwise. That's what you're trying to.
Yes, ma'am.
Okay, fair enough. Dr. Matthews, would you throw some light on how to analyze, and of course, we will of course comment on Anjali's presentation a bit later, on how to analyze a case series. What tools should we use, and to get the best out of a case series analysis, especially for rare disorders like this. All we may have is just a case series and nothing more.
Okay,
Stop
thank you,
sharing.
madam.
Stop sharing. Anjali, please.
Anjali, stop sharing your screen.
Yeah, sure, ma'am.
So thank you, madam. So thank you, Dr. Anjali. Now, any kind of a research study, whether it is case series or otherwise, has to be analyzed along some common parameters, of which the first question to ask ourselves is, what is the question that the researchers are trying to address? Now, as Dr. Rawat sir has highlighted in the chat box, the question itself is unclear. So when the question is unclear, whatever answer comes out will also be unclear. It will be like giving a student in a classroom a blank answer sheet and saying, write, without telling him what is the question. How then can we expect the student to write? So in the same way, the main thing which spoils this so-called research study is the fact that the question is unclear. Let us presume that the question is actually to get a cohort of people who have got some kind of primary immune deficiency, and then see how many of them have got interstitial lung disease, and then do the clinical, radiological, genetic, blah, 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 to describe and characterize those things. Now, if this is the aim, then there are two key things which are there. One is the PID, the other is the ILD. So naturally, it is understandable that each of this will have to have a specific definition. Here, it's missing for both of them. So PID has been collected from some case series of files. Now the basis for collecting just those numbers, again not clear. They are 976. They themselves mentioned later on that ILD may precede the PID, ILD may lag the PID. So unless they look at those 976 and follow them up over time, they are not going to be able to identify all the ILDs which are supposed to be present over there. Now, same way for the ILD, what is it that they're calling an ILD? Now, they have given a definition in their paper that includes three things: clinical, radiological, and biopsy. It's not or biopsy, it is and biopsy. The presenter has missed this point. So now, if that is the case, and you're diagnosing 11 children to have ILD, you can't get away with doing biopsy in 8. Can't do CT scan in 10 when it is one of the inclusion criteria. So this leads us to, have this bias because of inappropriate definition of both the conditions. Now, Dr. Anjali, CVID
Yes,
Mm-hmm.
is
ma'am.
not combined variable, it is common variable immune deficiency. Combined immune deficiency is a completely different thing. That is a spectrum in which things like SCID and all those kind of things come up, of which they had one child. But CVID is actually common variable. So this GLILD is a common ILD, not in SCID or combined immune deficiency, but it is in common variable immune deficiency. Anyway, that doesn't matter because that is only a minor point to the thing. Now, this is a retrospective study. Now, what is the problem with a retrospective study? The problem with retrospective studies is exactly as has been seen in this paper, that definitions are not clear, criteria for selecting participants is not clear, criteria based on which the denominator of participants was chosen, that is not clear. So this is what actually hampers a retrospective study. Now, a retrospective study with case series then doubles the bias, because case series is anyway biased and retrospective study has its own biases. So we end up with a peculiar situation in which question is also not clear. Some data also which are coming out are not able to be fit in, and so therefore we are left more confused than before. Now, therefore, it is obvious that the conclusion paragraph which the authors wrote, 5-6 sentences are given in that. Actually speaking, not a single one of those sentences comes from the data they presented in this study. These are general statements that they have made, that this is there, that is there, this is a treatment, that is a treatment, and all that. And if you look at it just from those sentences which they have written, then the problem is that none of that information is novel, because all that we have written there is already known, that steroid may work, steroid may not work, biopsy should be done, GL-ILD is the most common thing, and all that. So I think this research study, from the perspective of doing a research study, has contributed less than zero. But from the purpose of our journal club, it has given us some important insights about how not to do a research study and how not to present the journal club as well. Now, Dr. Anjali, for your this thing, because you come from a teaching institution, no? So usually in a journal club, first the paper is summarized and highlighted. We don't really go into the comparison with other existing adult or pediatric studies, because we are critiquing one paper and only asking ourselves one question: can I believe this study or shall I not believe this study, and what are the reasons for that? This will be a tip for you for future journal clubs as well. With that, I
Yes.
will close my remarks, and then if there is something in the chat box, I'll keep typing and responding. Thank you, madam.
Thank you, Dr. Joseph, for your brilliant remarks as always. So the choice of of course, Anjali gave me 3 articles and I chose this one for her because I wanted to highlight how a study should not, that is the reason to choose this. It was like a negative article to learn from. So therefore I chose this, and I thought it was talking something unusual also, apart from usual TB and empymas that we keep talking about. Any other question from any of the panelists that you would like to ask Anjali, or anyone, or to Dr. Joseph, or any one of us? I don't see any question. Any comments, Dr. Ajay Kumar, that you would like to make?
Yes, ma'am. Although this is a retrospective study and a very small case series, but there are some learning point in this. I also go through it. One thing is the cohort was very high, that 794 or 9, and only 11% they have identified ILD. So I think incidence is very low. I think so. Amongst the 11%, the main thing is 6 out of 11 has no respiratory symptoms. And this is our learning point. If we are investigating or we find PID cases, we also investigate for the chest uh, uh, findings for doing investigations. So this is one learning point what I learned from this journal article. Third one is there is uh, one is you, ma'am. This is autoimmune cytopenia in a significant number of patients. Autoimmune cytopenia, especially autoimmune thrombocytopenia, are observed as the first manifestation of the disease. This is again one of the learning for me. And for the resident, all of us know that tree bud appearance is not only for the tuberculosis, it may be due to those many other non-infectious causes, and this article is also mentioned. One question, one query is from my side is, in this it is written, according to some author, RV, residual volume by TLC ratio may be more sensitive indicator of airflow obstruction than FEV1 by FEBC ratio. Can we follow this, ma'am? Joseph sir, any comment on this? In this article it is written, residual volume by TLC ratio may be more sensitive indicator of airflow obstruction than FEV1 by FAPC.
So as far as we are concerned, the study is not designed to answer that question.
Okay, sir.
So
That
any
is the point.
interpretations they make or
Is-
statements they make are not trustworthy, no?
Okay, sir. Thank you, sir. So these are the questions. Although, sir, this article may give some insight. Although this is not, I think, not so up to the mark article. But yes, sometimes we have to take the retrospective study also to look for the many negatives in what I learned from you for your comments, sir. Thank you, sir.
Yes, so Dr. Anjali, if you have to publish a case series from your department, what thing which you remember so that in future your work gets some important research inputs or it might have some use. So how would you plan a case series from your department?
Sir, first of all, I would like to go for a prospective set of data rather than a retrospective data, and with a well defined research question that what are we addressing first. So, we have to make a research question first and then go towards what are we suspecting. Also, looking for a prospective analysis, sir, so that the data is not missed and the human errors are low. Could also try to have a control group, sir, so to minimize a bias.
Yes, so I think what Dr. Joseph has emphasized very important is that your research question should be very clear. Like for example, you are trying to publish a case series of ILD. So your definition of ILD should be extremely clear. So that data, if any else researcher want to use that data, then like for example, in this particular study, there were a lot of flaws which sir has told that the inclusion criteria was not clear, and the aim of the study was not very clearly documented. So I think whenever we, like for example, you are in a teaching institute, so whenever you want to make any case series retrospective of say or you are seeing some, like for example, you are seeing cases of bronchiectasis, so you have to clearly define what do you mean by bronchiectasis, what your inclusion criteria, establish whether they meet established criteria or not. And once you do that, whatever data you publish, that will be of use to future researchers so that they have got a clear inclusion criteria, that these are the criteria on which we had taken these cases. So that particular study would be of use for future. So I think one important learning which you get is that your research question should be absolutely clear, because if your question is wrong, your all the data that down the line is going to be wrong, because your start was wrong. So I think this is important learning which we get from this particular study. And I think the second important thing is that there were a lot of historical confirmation of ILD. So I think this is a positive thing, because if you get ILD which is historically confirmed, that adds to your weight that yes, you are dealing with ILD, because seeing a lot of CT scan data and clinical data, and apart from that, if you do histological studies, then that adds weight to your data. So I think this is one positive point in your study, that they had done a lot of histology. Otherwise, I think if you whatever sir has told, if you follow those things, then definitely your study material, it can be of use to later also. Thank you.
And when you have such rare diseases where the number is going to be less, so I think it's a good idea to have a multi-centric study. That is one thing even this study was looking at. So there you have a good spectrum of cases, a good statistician to tell you for rare diseases, the numbers of cases that you need for analysis may be a little lesser than what you need for any other study. So a good when you start a study, to understand what is the kind of number of patients you need to make the study meaningful, also I think would be a value addition. Consulting a biostatistician to start with may be of some use, according to me.
Ma'am, please ask from the mentor also, session mentor.
Uh,
Dr. Arpita,
Dr.
her
Arpita,
comment,
yeah,
her
yes.
comment, huh?
Dr. Arpita, you were not seen also. Yes, happy to see you. Yes.
Yes, ma'am. Actually, we searched papers with this research question only, that what is the what are the ILDs that are available in different inborn errors of immunity in children, and definitely there are many peculiarities about this paper, and it is definitely not the ideal way to conduct a study and even make a publication. But this is the largest, unfortunately, this is the largest and the only data available. Of the others are just anecdotal case reports. And there is another data from Egypt in pediatrics. And here, there again, they are focused on CGD. So just like this cohort is focused on CVID, common variable immunodeficiency, the Egyptian cohort is focusing on CGD. So this is very peculiar that out of 676 patients that they, 740 patients that they screened, they found 11 patients with ILD, and they were, out of which 9 were common variable and 2 were combined, but there were no CGDs. So there is definitely some sort of I mean, they have, it appears that even changed their objectives depending upon what data they obtained. So they started off the study thinking that they would select ILDs in IEIs, but once they found that the data that they had were mostly CVID, probably because of the ease of diagnosing of CVID in their center, they changed the objectives and they manipulated and modified the data. That was my impression. But unfortunately, despite so many large centers, these are the only few data that we have about ILDs in IEIs. So that is, I mean, that is unfortunate, and it actually evokes in us to conduct more such studies with a better research question and with the better knowledge, and equips us to conduct the study in a more planned manner.
Yes. Thank you so much, Dr. Arpita. ILD in children per se is rare, and ILD in an inborn in inborn errors of immunity, but it's a good idea. Good is further rare. So it is a good study to make us think that when we are dealing with patients with inborn errors of immunity, ILD could be also one of the manifestations that we need to look at and probably treat. So though maybe this study gives the base to say that more research is needed and more better studies, better multicentric studies are required for this topic. So it being rare, it needs definitely to make guidelines or to make any structured comments. We would definitely need more data.
But Dr. Arpita, no, CVID is a type of IEI because it is just a chance that they got only CVID in cases of ILD. So I don't think there is any wrong with that because
So, but it is a bit rare that they did not get any CGD. They
I
did
think-
not get A gamma globulinemia, because CGD is relatively common. So it appears to me that depending upon the ease of identification that they had at their center, they modified the objectives and published it that way. That's what it appears. I mean, I could be wrong, but because it is, the CGD is a relatively, and even CGD patients have granulomas, they have, due to recurrent infections, they have incidence of, they have autoimmune manifestations. So
Madam, all these IEI, they've got a strong genetic basis, and it was done only in Poland, Warsaw, in one city. So it is possible that the genetic makeup in that particular area, probably CGDs are not very common, or hypogammaglobulinemia are not very common, and there are more CVIDs. That's why probably they got more CVID. Because had these in multiple part of Europe or multiple continents, probably we might have. But it was done only in one city, Warsaw, where they did in 2 centers. So I think it is possible that the genetic makeup in that particular area is that probably they are getting more amount of CVIDs, they are getting less amount of CGDs, or it is possible because it is done only on one city, and we don't know what is the baseline or underlying incidence of CGDs in Warsaw. Like suppose if you are having that data that suppose incidence of CGD is very high in Warsaw, if they missed it, then probably we would have thought. But since we don't have that underlying background data, that what is the incidence of IEI in Warsaw, I don't think we can have this particular inference that they have tried to manipulate. Probably they were truthful whatever they found, they reported that probably we got only CVIDs and this is the incidence. So I think this could be without a background data we cannot presume.
Dr.
So that
Joseph,
would have been more insightful if they had shared the type of mutations that they had got.
correct.
Because if it is so that in that population, common variable is a common, is a relatively common occurrence compared to chronic granulomatous disease, then it would have been good if they had shared the mutations that they got that defined CVID.
Dr. Joseph, you wanted to comment?
Yeah. So the presenting team should not miss the purpose of this journal club. It is not for telling the audience about CVID or ILD or IEI. The purpose of the journal club is a paper has been allocated to the presenter to examine the paper and see whether we can believe and what can we conclude from it. So the entire focus of the last 1 hour has gone, in talking about different kinds of immune deficiency and this, which is not the purpose of the journal club at all. Now, for example, a good example of why we are straying from the facts can be looked at by the fact that all of these 11 children which had the inborn ILD in the PIDs, all are boys. So this means somebody can conclude that 100% of the ILDs happens in males and nothing happens in female.
Yes, sir.
It is exactly to avoid erroneous conclusions like this that we examine a paper for its methodology and not for rest of the stuff that we're talking about for the last 45 minutes. Otherwise, the listeners, there are only 7 attendees today, probably because of the Diwali holidays and all. The poor thing will go away with the misimpression that, in a journal club of IAP NRC, we are basically more interested to see what is the textbook information rather than the critiquing of the research paper. So therefore, we need to focus on that part. Otherwise, the teams will not get the benefit of this journal club session. Thank you.
So your point is well taken. I think when we started the discussion, you made the point, analyze the article for us threadbare, and then there was nothing more to add. So then the discussion went a little lateral.
Madam,
Bring us back to track.
Madam, purpose of the journal is already fulfilled by choosing this article by you. We just hear the important point from the Joseph sir regarding this article. This is also a learning point for us, sir.
Yes. Thank you so much. Any more comments? Otherwise, we will call it a day.
Thank you very much then all.
Wishing everyone a happy Diwali and safe Diwali and a healthy Diwali with less pollution and better lungs.
Thank you. Good night all.
Same to you.
Happy
Good night.
Diwali
Good night,
to
sir.
Good night.
Good night, sir.
Thank you, sir.
Hmm.
Bye, sir.
Good night, Dr. Kasi Bandaru.